Hello everyone, my name is Borbála Körmendy. I am a first-year ENT resident, and let me take you to a brief tour of middle ear surgery. As you can see, all of my projects have something to do with cholesteatoma. The first one is staging it, the second one is operating it, and the third one is follow-up. So let's start. What is a cholesteatoma? A cholesteatoma is a potentially very dangerous disease in the middle ear in which a small amount of squamous epithelium gets into the tympanic cavity and starts expanding there, destroying the structures of the middle ear in its path. It can be asymptomatic for a long time, but later on it can lead to otorrhea or hearing loss, and in later extreme cases it can lead to meningitis, large neck abscesses, or even epilepsy. It has two main types. The first type is a retraction pocket cholesteatoma. In our clinic, specialized for skull-base surgery and middle ear surgery, we see around 100 of these a year. And the other type is congenital cholesteatoma. We see maybe 1 or 2 cases of this. My first project has to do with this latter cholesteatoma, the congenital cholesteatoma. Since this is a very rare disease, we feel it is very important to have a reliable staging system to be able to correctly gauge prognosis, plan surgeries, and compare their results on a multi-institutional and international level. For this, for the longest time in middle ear surgery, people have been using the Bajcsy staging system. It is very widespread, very logical, very easy to use, but we don't have a clear evidence-based consensus on whether it's actually the best staging system to use to gauge prognosis. So our aim with my first project was to assess the clinical usefulness of the Bajcsy staging system for predicting congenital cholesteatoma outcomes. Our clinical question was whether the Bajcsy stage correctly predicts the likelihood of residual disease. So our population was all patients with congenital cholesteatoma. We were comparing the 4 stages of the Bajcsy staging system to each other, and our outcome was residual disease, which means that after surgery, a small amount of squamous epithelium is left over in the tympanic cavity, and over time starts expanding again and forms a new cholesteatoma. During our search and selection process, we have ended up with 13 articles that we have included into our systematic review phase, and 7 of these articles we have included into our meta-analysis. And we ended up with this forest plot. So again, our question was whether the proportion for residual cholesteatoma is different in the 4 stages of the Bajcsy staging. As you can see, in our studies, we had a relatively low number of patients. The most cholesteatomas in one article was 93. And all over, in the 4 stages, we had quite low event numbers, so we don't really have a lot of data to work with. And for the proportion, we ended up with very large confidence intervals and high p-values overall. So based on this, from a statistical point of view, we can say that there's no statistically significant difference between the stages. For us clinicians, this means that based on the currently available data in the literature, we are not able to say whether the Bajcsy staging is actually that great for prognosis, for predicting prognosis of congenital cholesteatoma. We also looked at the risk of bias across all of our key articles. And what we have found is that there is a tendency for missing data on people who were lost to follow-up and confounding factors. And also in many articles, it wasn't really lined out whether they used a standardized method to decide who was in which stage. So our conclusion for my first project is that we cannot properly assess the prognostic value of the staging system due to inconsistent reporting. What this means in the practice is that rigorous follow-up, this means second look surgery or dedicated MRI protocols, should not be omitted in early stages of the disease. And the implication for research is that we need more cases with carefully documented, long-spanning individual follow-up data. I am very excited to share with you that this project has been accepted for publication in the European Journal of Otorhinolaryngology. My second project has to do with how to do surgery on cholesteatoma. Unlike what we have been taught in anatomy, the tympanic cavity is not a box. It is more like a very complicated cave with many little pockets that sometimes can be a challenge to explore. Traditionally, we have been using operating microscopes for cholesteatoma surgery. This is really great because surgeons can use both of their hands, but microscopes only offer a line of sight vision. In the last few decades, thanks to the rapid development of endoscopic optic techniques, we have been able to introduce endoscopes into cholesteatoma surgery. These are great because with an endoscope, you are much more able to explore all of these little nooks and crannies of the tympanic cavity, such as the facial recess or the sinus tympani. But the drawback is that surgeons are only able to use one hand, so it can be quite a challenge. In our results, what we have seen is that at the end of a microscopic middle ear surgery, in 50% of the cases, when we have thought that we have evacuated all of the cholesteatoma tissue, when we looked into these hard to explore places with an endoscope, in 50% of cases, we still found leftover cholesteatoma tissue. And during follow-up, what we have found is that in 0% of the cases have we found new cholesteatoma growth in these places. Obviously, there was some in other places. That is definitely a lesson for us in our future practice. But we were very happy to find that endoscopes can provide helpful intraoperative control of cholesteatomas during middle ear surgery, and they can actually lower residual rate. We are done with our manuscript writing process, and we have submitted our project to the Annals of Pathology and Rhinology and Laryngology. And my final project is a really exciting topic nowadays, is following clinical follow-up of cholesteatomas. Residual cholesteatoma can be quite a problem. The incidence is around 5 to 35% per year. And the most contemporary method of following up patients is using dedicated MRI protocols, which is the non-epi DVI MRI. We really like this protocol because, as you can see in the yellow bracket in the picture, cholesteatomas, unlike on CTs, basically light up when you look at them with these DVI MRIs. But the problem is that even in Western European countries and in industrialized, very rich countries, these DVI MRI protocols are hard to access. So it would be very interesting from a clinical point of view to estimate postoperative growth rates of cholesteatomas in order to be able to determine the optimal length and timing of follow-up after surgery. So we looked around in the literature and we mainly found two types of data on cholesteatoma growth. Either we had two MRI pictures of the same cholesteatoma at a certain amount of with a certain amount of time between them, or we had an MRI done of a patient who underwent surgery. Based on this, we wish to determine an optimal follow-up length and the timing of this MRI protocol. So we started a selection process with 10,000 articles, and we ended up with 19 that we have included into the growth model that we are intending to create based on this data. Right now, we are done with the data extraction, and we are currently in the process of creating this model and doing the risk of bias analysis. So again, these were all my projects, and I can't wait for your questions. Thank you for your attention.
Borbála, thank you for your excellent lecture. It is really fascinating how complex is the cholesteatoma disease.
Thank you so much. It was amazing, your presentation. I just want to ask you that if this spot-6 staging system doesn't work, do you have any other options in the clinical practice, or what can you use instead?
Yeah, actually, thank you for the question. The spot-6 staging is, in fact, not the newest staging system that we have. It was established in 2002, and from 2021, we have a new staging system that can be used for all cholesteatomas. It is the European-Japanese consensus staging system for cholesteatomas. But since this staging is really new, it's not that established yet, and it includes congenital cholesteatomas with retraction pocket cholesteatomas, and also it's not, there are some stages within this new staging system that are not that ambiguous. Although we don't really have any clinical evidence for the POD6 staging, I think it's still easier to use in a clinical setting.
Thank you for your presentation. I would like to ask that how big are these cholesteatomas? I mean, how can we imagine them in size, and which was the greatest, or how big was the largest one?
So cholesteatomas are usually smaller in size. When it comes to congenital cholesteatomas, when we are lucky, we incidentally find it in a child. Usually this happens when they are going to school, everyone goes to the doctor, they have their ears looked at, and voila, they have a congenital cholesteatoma. Usually these are 1 to 5 centimeters long. But in the literature, there are also giant cholesteatomas. For example, I read a case report of a 65-year-old male for whom it was also an incidental finding, and I think it was 7 centimeters by 2.5 by 3.8 centimeters. So they can be quite large. It expanded into the intracranial space. So I think it's really interesting that he did not have any symptoms. And actually, in many patients, congenital cholesteatomas can envelop the hearing ossicles, and since they are really great at conducting sound, for many people, although they might have quite developed disease, they don't have any problems with hearing. So it can be quite challenging.
My question is related to the last one. Due to my knowledge, the cholesteatoma can be originated or can be advanced to the mastoid process.
Yes.
So many years ago, even the mastoidectomy was used for dissecting these cholesteatomas. Is it totally outdated already? I mean the mastoidectomy, or now the diagnosis is so early that it is already not needed?
Thank you so much. That's an excellent question, actually. So with the emergence of endoscopic techniques, we are mainly talking about cholesteatoma that is confined to the tympanic cavity. Because if you're using an endoscope, especially if you are using a totally endoscopic technique, you are not able to explore the mastoid that much. If you are going to operate on the mastoid, which obviously is still a thing, you will definitely need to use the operating microscope. So although it's not that much of a trendy topic, it definitely happens. We can have the most developed imaging protocols. We can have the most rigorous follow-up for patients. Cholesteatoma can be so sneaky that even in advanced cases, we might be dealing with no symptoms at all. So it's definitely a very relevant topic, and it is also what my supervisors have published extensively on. In their research, they were looking at cholesteatomas expanding into the mastoid cavity, and to stop residual cholesteatoma to go back into the mastoid cavity, they fill up the drilled and emptied out mastoid cavity with bone pate, and they also have different synthetic materials for that.
I would like to go back to the basics and asking you that why the congenital cholesteatoma is congenital. And the other question, is there any difference between the congenital cholesteatoma and this retraction, something what you mentioned?
Yes. Let me go back to my first picture, actually. So congenital cholesteatomas are thought to occur when the brachial clefts are still developing. They are thought to come from some squamous epithelium being left over within the tympanic cavity. They usually look different than retraction pocket cholesteatomas. In the Hungarian lingo, people usually call them a spider's egg. They are very smooth, and usually it's just this little bubble behind completely intact tympanic membrane, whereas in retraction pocket cholesteatoma, it's actually a part of the tympanic membrane that gets sucked into the tympanic cavity, and within that pocket, we see a proliferating mass of squamous epithelium that is expanding inside the tympanic cavity.
How frequent could be this, so the prevalence of this finding? How frequent?
In our clinic, we are a middle ear surgery center, so we see quite a few cholesteatomas.
Yeah.
We see around 100 retraction pocket cholesteatomas in a year, and maybe 1 or 2 congenital cholesteatomas. But for some reason, in Eastern Asian populations, congenital cholesteatoma is much more frequent. They see in a clinic that's our size maybe 10 or 15. So that is why most of my key articles for my congenital cholesteatoma projects were from Japan and South Korea.
Okay. Thank you.
I would have the same, like my colleague, but still a question, is there any other disease, internal-medicine related disease, which comes together or related to the cholesteatoma development? Or do you have any other issue? How can you raise the possibility that this cholesteatoma at least exists? Because in some cases, I wouldn't say some cases, I don't know how many percentage of the cases, because the last occasion when I heard about cholesteatoma was when I was in the 4th year in my university, so I have no idea, but to my best knowledge, the vast majority, some percent of the cases are absolutely so there is no any symptom related to that. So is there any other disease which comes together with cholesteatoma and can be recognized and raises the possibility that there is cholesteatoma in the background?
Yeah, absolutely. Unfortunately, I can't say that there is such a disease for congenital cholesteatoma. Usually there are genetic factors. I have seen many case reports where children had different genetic diseases as well, but there's not 1 or 2 known genetic syndrome where we think about congenital cholesteatoma. But if you remember in retraction pocket cholesteatoma, I talked about the vacuum inside the tympanic cavity that sucks in the tympanic membrane. Whenever the ventilation of the tympanic cavity is a little bit hindered by, for example, craniofacial dysplasia or maybe just frequent upper respiratory tract infections, we definitely think about the possibility of a cholesteatoma. I'm not saying that that it is routine for us to look at these patients, but that is definitely a huge part of the population that we see. Also, there's a new theory for how exactly the tympanic membrane ends up within the tympanic cavity. It has to do with mucociliary transportation. So I believe there was a study that looked at patients who had mucociliary dyskinesis syndrome, but unfortunately there was no direct association between cholesteatoma and that syndrome.
And what does it contain histologically? So what if you make some tissue investigation?
Histologically it's squamous epithelium. It basically looks like an epidermoid cyst. Histologically it's the same.
In your first topic, if you go to the forest plot, you have almost everything is 0. Not everything, but most of the stuff is 0. So I believe all of your studies were either case reports or case series.
Case series.
Case series, yeah. And do you think that in this case publication bias has a really huge impact on these results?
Well, since congenital cholesteatoma is quite a rare disease, so if you come up with a case series of even just 15 or 20 congenital cholesteatomas, you're going to look cool in a conference. So I don't think that publication bias, as in like small study effect in itself, is a problem, but I definitely think that since these are just case series and not a case control study or something with a more rigorous methodology, it's definitely a problem in the literature. So that is why we decided to publish, although we had such a high risk of bias.
Yeah, I'm just asking this because we can see that statistically there's no difference between the 4 stages, and maybe everyone just reported the successes. So.
Yeah, definitely.
That was very interesting again. I'm unhappy that you had another project about the tympanoplasty, and I couldn't see it here.
Oh, we just paused that. We still have that. It will be going on, but we just decided to concentrate on different
That was
project.
also an interesting one. About the last topic here, it just came to my mind that are you expecting the growth of the cholesteatomas to be linear? Because as far as I understood, you are collecting between 2 MRIs or surgery and MRI, you're collecting growth data. But as I can imagine in the three-dimensional space, in different part of that closed area, growth won't be linear. No? I mean, for 2 years it's not growing, then it just goes out and just causes a huge cholesteatoma. But how is these things grow?
So we still have time, so I will definitely go into this. So we have already started our data extraction, and what we have found in all of our key articles is that most of them were looking at either the largest diameter of a cholesteatoma, or some of them even published the 3 diameters of the cholesteatomas. There's going to be like a huge risk of bias. But that is, I believe, one of the answers for your questions. We are going to be looking at the largest diameter of the cholesteatoma. And since we don't have month-to-month data for these cholesteatomas, between the 2 MRIs, in some cases, even such a long time as 1 year, 1 year could pass. Our statistician decided that we are going to theorize a linear growth rate, and our measurement that we have chosen for these cholesteatomas is going to be square millimeter per year. Sorry, millimeter per year.
So your assumption is a linear growth.
Yeah, we are going to assume linear growth, but obviously that is only an assumption. We cannot be 100% sure. We did not have enough data to make a real model. We don't have enough data points to satisfy a model that would need as many parameters as a hyperbolic curve, for example.